All right, we're 2 minutes after. Let's go ahead and get started. Good afternoon, everyone, and thank you for joining the Brothers of the Tulsa Alumni chapter of KAPsi fraternity in our 5th edition of what we like to call our Kappa Awareness Summits. We pray that you learned something new from these summit series that will benefit you or someone you care about and enrich your lives in some way. This month's topic is men's health. My name is William Becknell, and I will serve as your moderator and timekeeper today. As moderator, I ask everyone to place your phones and/or computers on mute so as to allow the speakers an opportunity to get through the answers clearly without distraction. This month, we're going to do things just a little bit different, and there will be no PowerPoint presentations or anything like that. It's an open format, and I would encourage everyone to ask questions pertaining to men's health about yourselves or someone you care about. And in doing so, please open a new chat window and send a direct message with your direct message to me with your questions. Our goal is to be concise, to the point, and not belabor any question or subject. In the event that we do not get to cover your questions, please, because of time, please send your questions to KAPsi Tulsa Alumni @gmail.com, and we will address your question in the form of a response via email. Please visit our YouTube page at KAPsi Tulsa Alumni for previous summits, and be on the lookout for this one to be posted within a few days. Now, as your timekeeper, my commitment to you is to not exceed our 1-hour slot in order to remain respectful of your Sunday evenings. I'd like to take a moment to acknowledge our pole mark, Brother Kiwan Koba, for his leadership, the brothers of the chapter for their support, and a special thank you to my brother, Dr. Malcolm Buford, for his leadership in recruiting our speakers. A big yo to him for that. Our speakers for this afternoon are specialists in the field of men's health, Dr. Brian Hall, pediatric physician, and Dr. Jonathan McGee, family doctor and owner of Essential MD. Welcome, gentlemen. It's a pleasure to have you with us today, and we appreciate you taking time from your families to do this with and for us. If you don't mind, please give us a glimpse of yourselves, your backgrounds, and what brought you into medicine. From there, we'll move into questions. Go right ahead, Dr. McGee, if you'll start for us.
Sure. So I am I'm originally from Little Rock, Arkansas, and moved here to Tulsa about 15 years ago to go to residency. I enjoyed just about everything in family medicine, medicine rather, and so decided to do family medicine. But having played college football, decided I wanted to do a fellowship in sports medicine, and to keep me close to the athletes. So that's what I did, and thankfully it's just been fun to get a chance to hang out with patients of all backgrounds, whether they are athletes on a regular basis or weekend warriors, former athletes or wannabe athletes.
There you go. All right, Brother Hall.
So I'm originally from Kansas City, Kansas. I went to college at Xavier University of Louisiana, where I pledged Beta Iota fall '97, and went back home to med school at University of Kansas. I have also done a fellowship in critical care pediatrics, but I do general pediatrics, taking care of our young men from birth up till I can hand them off to Dr. McGee. And finally, I want to add, and I think I'll speak to this this evening, but I'm also a patient of Dr. McGee. So, I'm hoping to learn something too tonight.
There we go. There we go.
No pressure.
All right. Well, fantastic, gentlemen. Dr. Buford, if I may defer to you for a moment. I know we had discussed a couple questions on your docket, if you will.
Yeah, so I appreciate Mr. Becknell, Brother Becknell, giving me the opportunity to be a part of this in this fashion. And I'm indebted to Jonathan and Brian for participating as well. I did want to say a little bit of a disclaimer, because we're going to touch on some subjects that hopefully will edify us and will allow us to better take care of ourselves as well as those that we care for. In order to do that, you have to step outside of your comfort zone. And so we're going to go outside of our comfort zone a little bit, gentlemen. and ladies, if you're on, I can't see everybody on, so forgive me. But I wanted to just clarify and somewhat of a disclaimer say that some of the opinions that are expressed tonight don't necessarily represent Kappa Alpha Psi fraternity, don't necessarily all represent Tulsa Alumni Chapter, its leadership, tenets, or its objectives, and that I do have references and documentation of every number that you hear and every reference to materials and studies that are going to be presented. I want to give a little bit of a background. I'll take a couple of minutes and talk about the history of healthy people. So Healthy People in 1979 was actually the title of Julius Richmond, who was the Surgeon General at that time. He wrote a paper on certain issues of report entitled Healthy People, the Surgeon General's Report on Health Promotion and Disease Prevention. In 1980, with the Department of Health and Human Services, the Office of Disease Prevention and Health Promotion released the Healthy People Initiative of 1990. This initiative, which evolves every 10 years, was supposed to be incorporating emerging trends and evidence from multiple sources and refocusing its goals at helping to accomplish certain things federally supported and backed over the years in healthcare, okay? In 1990, the goals were simple: decrease death and increase independence amongst older adults. In 2000, changed: reduce health disparities and achieve access to preventative services for all. In 2010, it changed again: eliminate health disparities. Understand, that was rather than just reduce them. And improve quality of life. In 2020, it was high quality, longer lives, free of preventable disease, disability, injury, and to achieve health equity. We're going to touch on that one. In 2020 or 2030, the initiative that just started 2 years ago was to increase focus on equity, health literacy, and social determinants of health and well-being. So I want to take a moment because we hear these words thrown around a lot: equality versus equity. Equality, as defined by the Merriam-Webster Dictionary, is like or alike in quantity, degree, and value. But equity is justice according to natural law or right, specifically freedom from bias or favoritism. There's something in medicine, and a couple of our mutual friends are well familiar with implicit bias. And implicit bias is there is a default bias against certain groups, and we're trying to overcome that, and that's where equity comes into play. So the key parts, though, to this history of people are health conditions, the behaviors, populations, settings and systems, and social determinants of health. This is important because people need to understand disease is not just what you did or what happened to you. Disease is a combination or conglomeration of multiple things. And so our government, the CDC, the Departments of Health and Human Services, are focused in this initiative that is now 40 years of age, and they're worried about the social determinants of health, as we all are. Those being economic stability, education, access and quality, neighborhood and built environment, social and community context, and health access and quality. Obviously, as physicians, health access and quality is a big thing. But I would be remiss if I didn't talk minimally and just hint on the fact that for the first time in our history as a country, we have had rights removed. It impacts healthcare. It impacts healthcare on multiple levels. And this is an apolitical statement. It is merely an observation of a fact. We now have more of patient populations that are at risk because they don't have access to care. So with that, we need to talk a little bit about, or at least I'm going to ask these two gentlemen to talk about how they anticipate addressing this concern amongst their men and women, their men and women patients. Because you not only have the acknowledgement of your female patients who are going to be concerned, not just those that are of childbearing age, but people who are planning, who are trying to be responsible and planning for families. And you also have men that are now going to have to look at contraception in a different light. And that is not something that the record would show that we have been strong at really discussing with our patients, contraception. So I'd like for us to follow somewhat of an aging chronological order with Dr. Hall first on how you plan on dealing with the discussion of contraception amongst parents and young kids, and then of course move on to Dr. McGee. You're on mute.
So one thing that's very important for me on this topic is talking to our young men, both in high school, going off to college. And, you know, we really are going to need to reinforce our discussion on the use of condoms, on what we are doing sexually, because, you know, we've talked about for many years the importance of sexual practices and what you know, having a baby can mean for your life. But it's going to be interesting to see how things are evolving here in this next year after this decision that was made.
I would simply add to that, Dr. Buford, the conversation has to be blunt at some point, and I think now is the time. I simply tell young people, I tell adults as well, you know, the ones that are younger, who are, you know, in their mid-20s or whatnot. I have some children I take care of as well, but I just tell them all, protect yourself and protect your future. I also tell people, you know, sometimes I can be fatherly at times in my office, but I would tell them things I would tell my own children. Listen, because, you know, if it's good for the goose, it's good for the gander, they say. But at the same token, I simply say, you must wait to have sex. Just, that's not something for people to do that, in particular children. And yeah, you get into it, your hormones kick in. I have a couple kids, 13, 14 years old, who are very sexually active. And so we're catching kids, you know, really early. 13 sometimes might be a little bit late. If you think about it, that's one of the reasons why they started doing the HPV vaccinations at age 11, trying to catch kids before they become sexually active. So we have to be particularly blunt when it comes to sex. It's an uncomfortable conversation. Kids don't want to talk about it. The parents don't want to be involved sometimes, but it's time out for that. And we have to, as physicians and caregivers, we have to address these hormones and quit ignoring the fact that they don't exist. And so if we talk to them about it and help them to know, they can hear their bodies, they can know what's going on, they can also protect themselves. Being a parent is a heavy decision, and I think it should be one that's met with much thought, much prayer. And following all of that, I would say that sometimes things happen, man. So not only do we have to, I believe, insulate young people, insulate adults even, because sometimes, we're out here making crazy choices or just living reckless. And that can be problematic if we are living in such a fashion. So avoiding that reckless behavior, being intentional about what you're doing so that you can protect yourself again, as well as protect your future. And then when things happen that aren't ideal, we have to make sure that we have still some love to support the people who are in a situation where they don't have the most ideal scenario. So hope that lends an answer.
Yeah, no, I think that's great. I think it's important too. You touched on HPV vaccination and the age, and that kind of serves as a good segue, because sexually transmitted infections are a very real problem for our youth. We know that 1 in 5 persons in the United States have an STI, and that in 2018, around 68 million infections were recorded, 28 million of which were new, and 50% of those were amongst people aged 15 to 24. So when we look at the prevalence and the incidence of STIs, the most common and the most pervasive is HPV. It costs, or the cases are something like 42 million, with 13 million in 2016. The vaccination started in 2009, and yet boys were not included until 2013 for immunization. Can you all talk a little bit about HPV vaccination and the discussion with parents or with your patients on how to prevent some of these very prevalent and communicable diseases?
Very well. So one of the thoughts I have, because we have a lot of parents today who are not interested in giving the HPV vaccination to their children. But I simply put it like this. HPV, 95% of it, it's a virus. 95% of it goes away in 2 years. But you don't know which virus strain you're going to have. And so, you can have, young ladies can have abnormal pap smear, or you could have genital lesions, warts, things of that nature. That's what the boys get. But the real incidence is you can have an effect on your ability to have children later, but you can also, just over some careless decisions that you make as a teenager, right? You can also have the risk of cancer, right? So reducing that risk of cancer, it doesn't matter what type of cancer, but when we have a vaccination that can virtually reduce your risk, minimize it rather, such that you don't have that same risk of developing cervical cancer, that's a home run. We are sexual beings and we have to respect that. So people are going to do it. And if we can catch kids and put them in a safe place. I've had some adults actually, who are single, who decided, hey, because they had an age limit on it at 26, I believe it was. But I've had some people come out of pocket who are over 26 years of age, who say, hey, I'd rather have that vaccination because I know what I'm about to do. And you have to, at some point, be responsible.
And so I think what I add to it in my discussions, both with parents, if they have concerns about the ages that we generally do, but also, Brother Becknell, if this might transition us towards some particular questions that those in attendance might have. But I often tie my discussion into what we can do now, what we can address now, health-wise, in our lives to prevent complications in the future, to minimize our risk for disease progression in the future, or just to not have to deal with certain things, because for all of us, I think being aware of aspects of our health, knowing some of the things, regardless of our current age, that we can do to reduce our risk of having disease complications and health complications that are affecting our daily functioning, and not having to that statistics show that we, especially as African Americans, deal with on a greater degree.
Yeah, I think it's important to note, and not just HPV, because that is a huge thing. I mean, it's a preventable complication. I think that's the not the irony of it, but I think the frustration of it is that it's something that you can prevent. We know that variants 16, 18, and 30, we know the ones that can actually come up. And if somebody actually gets tested and they have a genotype done, then we know their overall risk of developing cervical cancer or penile head cancer, let alone the condyloma, the warts that happen. But with other STIs, 25% of the cost in managing STIs is women, which means 75% of managing sexually transmitted infections is for men. That's a man problem. That's not a woman problem. 26% of the cost of STI treatment is with those people ages 15 to 24. In 2018, we spent $16 billion on lifetime medical cost on STIs, 1.1 billion on things like chlamydia, gonorrhea, and syphilis alone. So they have a financial impact on us. One of the other diseases that often gets transmitted is hepatitis C and hepatitis B. And they can cause liver disease. And we're going to talk a little bit about liver disease, and we can touch on NASH toward the end. But given the fact that hepatitis C, I remember in medical school when I first learned about it, and about how it was known as non-A, non-B up until 92, because we didn't have PCR at the time to even catch the virus in its DNA. And now we have treatment algorithms and therapy. Can you all talk a little bit about hepatitis B, C, and in particular, hepatitis C therapy?
Well, one of the first things that I could say, there are multiple different genotypes, as you mentioned, of hepatitis C. And we've seen, for the folks that are, 55, 60 years old, or more, we've seen folks who, probably have had family members who live with hepatitis C, and sometimes didn't know it. Matter of fact, it's a screening test by the U.S. Preventive Service Task Force to screen people age 60, I believe, and above today for hepatitis C, because in many instances they live with it, had no idea that they had it. But we have treatments for it. Historically, we had interferon as a medical treatment that wasn't, it was just a horrible drug by and large, to put it bluntly. But at the same token, people ended up having some challenges with treating the hepatitis C from that. But we have newer agents today that are much more accessible, only take about 6 weeks to get you over the hepatitis C, depending on the genotype that you have, or the version, the strain of it. And it can actually be very easily done. Commonly, I send patients to the gastroenterologist for this type of treatment. There are some family docs in town that are treating it themselves. But it's just a matter of comfort level. But it's just one of those things that you can treat hepatitis C. And it's important for us to get the screenings done, get the treatment as well. The ultimate risk of having hepatitis, I'll stop after this comment, hepatitis can lead to liver failure. And nobody wants to live with liver failure. I tell my wife all the time, just for you guys, obviously I'm not a cardiologist, and I know all the noops in here love the heart. But at the same token, I always tell my wife, I said, she would say, I love you with all my heart. I said, I love you with all my liver. Because, you know, even not being necessarily a GI specialist or liver specialist, hepatologist, if you don't have your liver, you will not live very long. And so that's one of my thoughts there.
There was a question. I don't know, Will, if you want to take it or you want me to go ahead.
Go right ahead, bro.
The question says, what age do we have these conversations with young people? And what can community and social organizations do to educate? So, Brian, you want to, Dr. Hall?
So I'll speak to that. Definitely as a pediatrician, when it comes to the topics we've discussed already, as well as our sexual health, reproductive health, you know, those conversations, even in the public schools, are starting in, you know, 5th grade, 6th grade. You know, the best way we can go about things are either for our own children going to routine, you know, well child examinations, but then for us as adults, you know, going to regular, whether it's every year or every 2 years, a regular doctor's visit, you know, just to be sure that we're both talking about getting screenings for, as well as, you know, getting treatment for various health conditions. And one of the personal best practices for me is to openly talk about these things with the people that we interact with. So again, as a patient of Dr. McGee, you know, I'm telling the people that I know that he's my doctor, but that I've also actually gone to see him, you know, and having that positive peer pressure, especially for us men, on just going to the doctor.
I apologize, Doc. Go right ahead.
No, I was just going to say, either Dr. McGee or Dr. Hall, can you talk about some of the generic symptoms of hepatitis or liver dysfunction as a whole?
I would say just one of the things that we can commonly think about would be jaundice, right? So your skin becoming yellow, your eyes becoming yellow. Most of the time people have some type of belly pain. So hepatitis happens and there are different strains, right? So A and hepatitis A. So we have the hand washing, you know, every restaurant says employees must wash their hands before returning to work, right? Hepatitis is easily transmitted. what we call fecal oral. So, you don't wash your hands when you go to the restroom and you go put your fingers in somebody else's food, boom, you have hepatitis A, which is the other reason why we talk about one of the mandates was that, you have running water in all of these food trucks, right? So people have to have, they have to be certified because you have to be able to wash your hands, things of that nature. Hepatitis A is probably the most common thing that we see, but hepatitis is hepatitis. So you can get jaundice, you can get very sick in your belly, vomiting, things of those natures.
All right, Jim.
Another thing, and to piggyback off my previous, my previous discussion of our regular visits, a lot of hepatitis C infection or chronic infection with hepatitis C until we get to more significant and potential end-stage liver damage is asymptomatic.
That's correct.
And so again, if we're not presenting to the doctor on a regular basis, there's things that we can do and we have to learn about in taking care of or managing end-stage liver disease. But in having our regular visits and getting screenings for things, whether we think we fall into the category that could be affected by a condition, or not, is the way that we're going to catch, obviously hepatitis C, but a number of conditions, at a very early stage, where what and how we manage it is so much easier and so much potentially less scary than we think could be involved.
Absolutely. As a good transit point, a question came up about the shingles vaccine. And just as an aside, so hepatitis C, hepatitis B, hepatitis A for that matter, are all viruses that are transmitted and they infect the liver, but other viruses do as well. For instance, Epstein-Barr, CMV, but the chickenpox virus, the varicella zoster virus, that can also cause a hepatitis, causes chickenpox and causes shingles. So can you all talk about Shingrix or the shingles vaccine, particularly I think Jonathan, Dr. McGee, and how you're utilizing it or implementing in your practice? What age people should get it, when they get it, how often you renew it?
Yeah, so the Shingrix vaccination is a 2-shot vaccination. You want to get it about age 55 or so. And then there's this vaccine, 60th maybe. The cool thing about it is that if you didn't have chickenpox, then you're not able to get shingles. Right. So most of our young people today, I've seen probably 2 cases of chickenpox in my career. I had chickenpox as a child, but right. But the kids today, if we're doing our work, effectively, kids don't get shingles. So they take the chickenpox vaccination now from, say, Brian, Dr. Hall, or wherever they go, they get these vaccinations. They don't have this risk down the road. But if we can do the shingles vaccination, the challenge is that a lot of people have shingles outbreaks at about age 30 and 40. I've seen several patients that have shingles, and there's really not anything you can do other than some steroids and antivirals in the interim to prevent. You can't prevent it necessarily. You have to just treat it. And so the Shingrix vaccination it reduces that shingles outbreak once you get older, when your immune system is a little bit weaker. But there's really nothing else we can do at this point.
And I want everyone to be aware. It's because we have been since late 90s have been doing routine vaccination against chickenpox, that being effective, and thus there is not as much chickenpox going around in the community, that those of us who've had varicella, who've had chickenpox, as a child, aren't getting little exposures to the virus on a routine basis, keeping our immunity's memory of how to keep it at bay, current. And so it's because of the effectiveness of the varicella or the chickenpox shot is why we need Shingrix.
That's true. I actually, just to throw in just a thought real quick. One of the unique things is when I was a child, and I'm into the 40s now. So the thing about it, the world seemed to be a lot bigger as a child. Hardly anybody moved outside the contiguous 48. If you didn't live in the United States, if you lived rather in the United States, you didn't really get across. You had to have a whole bunch of money, a whole bunch of resources to get across the pond to Europe or to Asia, right? You may have known some international students once you got to college, but did you ever go visit them, right? But now the world is so much smaller, and it speaks towards the reason for us to have vaccinations, because you can take $1,500 and go across the world, right? And see whoever, do whatever, and the world is a lot smaller. And in the same vein, not only are you able to do that, people from other countries can come here, right? And so the instance of just crossing the border. So we may not enjoy all the healthcare opportunities that we have here in the United States, but Mexico is still a third world country, right? So you have patients who come from Mexico who have not had the same access to vaccinations that we have here. And there's a risk of disease, right? And the 2 cases of chickenpox that I've seen as a physician are from folks from Mexico. And so we argue a lot of times about not wanting to take vaccinations. It doesn't matter which one you want to talk about. But there are people who don't have that access that we have. And so it's really important to get the vaccinations to do the prevention. Preventative health, it's an old adage, an ounce of prevention is better than a pound of cure.
Definitely. Gentlemen, if I may back up for just a little bit, there was a question here about what's a recommended age for children being vaccinated for HPV? I might have missed that part in your discussions.
So by routine and current U.S. immunization schedule, we routinely begin HPV vaccination at age 11.
Okay.
And it can be given as early as age 9. If a person, and so the Gardasil or HPV vaccine, so is FDA approved for use up to age 45. And that's because, again, as Dr. McGee said before, most and as I focus and emphasize to parents, the most important part of the HPV name is the H, is the human. Mm-hmm. So as an adult, having having HPV is a part of adult human life, and most we get it and it doesn't cause anything, and our immune systems take care of it. But certain strains are associated with the cancers, and those strains are included in the vaccine, and thus, someone who may not have, been infected at a younger age, or with a strain that does not lead to cancer could still be, at risk. So age 11 is when we routinely start vaccination. If someone begins the vaccination with Gardasil after the age of 15, it requires 3 shots. If you start under 11 and have at least 6 months between the first and the second, then 2 shots are effective at giving immunity. And so again, when people have questions or concerns about the age, that we're starting to immunize children, for sexually transmitted, what I tell them is, just that fact there. If we start at 11 versus if we start at 16 or 17, we have a better immune response at the younger age.
Awesome, awesome. We have another question here from Dr. Harris. What are your thoughts and perspectives on herbal and holistic medicines for preventative healthcare? That's actually bowling right down my alley, Doc. Thank you very much for that question.
So I would say my general answer is there is a role for various forms of what we say alternative healthcare. But as a physician, as an allopathic physician, I am going to always want to incorporate it into our overall, and not disrespectfully, but scientifically proven treatment options, care plans. And so the key, in my opinion, is 1, letting your physician know either that you already are or desire to use herbal or various alternative medications. But with the healthcare disparities that we as Black people face, I honestly do not and get concerned when my people are wanting to do herbal or alternative, instead of kind of routine Western scientific treatments. I think, again, combining them together, having those conversations with your doctor to figure how we can and should incorporate that into a comprehensive treatment plan is the best way to go for me.
Understood. Thank you, Dr. Hall. How about you, Dr. McGee?
I would simply add to that, one of the things that I think Dr. Hall said that is perfect is tell your doctor about what you plan to do, about what your goals are. For me, again, I'm an allopathic physician as well. So my training is going to be, very black and white, but we are individuals. And so my job, in my opinion, is to be an ally for you. So, but that's a two-way street. So I have knowledge and you have a body. And if you feel like you would respect the knowledge that I have, and I can also respect your body, we can get along really well. It'll be a great symbiotic relationship in the sense that if you want to use holistic treatments, things of that nature, let's just do the diligence of checking the labs. Let's work together. And if there's a point at which these holistic treatments are not effective, then be willing to make a change and do or incorporate at least some traditional medications. Because at the end of the day, what we want is for you to be well. You don't want to run around here. I was treating my diabetes with cinnamon for umpteen years, and you show up at the hospital in the emergency room with a toe about to fall off, or they're having to do a full amputation of your leg all the way up above your knee, and you said, "Well, I was taking that cinnamon. I refused to exercise. I didn't want to change my diet. I didn't want to take the dialysis. All these different things. You can holistically see yourself into the grave if we're not careful. So make sure that if you use holistic or alternative medications, herbal treatments, things of that nature, do the diligence to check the labs. The labs don't lie. It's an objective way to say, hey, and then to see if there's an effective strategy for you, because the challenge is that we see there can rather be effectiveness. It's just not sustainable effectiveness, right? And that's the reason why it's over the counter. It's not as heavily regulated as prescription drugs, things of that nature. So there's not going to be as much consistency. So.
Understood. Thank you very much. There's another comment in the chat. Please speak to the impact of diet and exercise on the incidence of disease and prevention.
I would simply say diet and exercise are paramount towards overall health. We often think about the value of diet and exercise as it relates to just simply, I don't want to be overweight. I don't want to have high blood pressure. I don't want to have diabetes, all these things. And we think about it so many times as a way to avoid certain conditions. And it's great for that. But even if you do have high blood pressure or diabetes or whatever the condition may be, you can still exercise and eat right so that you can limit the downstream effects of those conditions as well. Lastly, we overlook sometimes the effect of diet and exercise on mental health, right? And I simply say, diet and exercise make a difference for serotonin levels, right? So a lot of people are anti-medications for depression and anxiety, but they don't want to eat right. They don't want to go exercise, but you can't ignore the effect, the positive effect rather, on the moods and serotonin levels from using appropriate exercise consistently, as well as limiting the amount of processed foods in your diet. The incidence of processed foods increases the risk of depression and anxiety, and America is full of them. If we can reduce those things in our diet, exercise consistently, we would have less mental health issues, assuming we talk to people too. Okay.
And I just, to piggyback on that, with regard to diet and exercise, for those of us with spouses, children, family living with us, going beyond the benefits of the increased diet and increased exercise and changes in diet for our individual health is that we make it a change for the family. And because even if it doesn't directly affect or pertinent to our children or a spouse, it can set up and help develop healthy habits, that everyone, can espouse to and stick with. So, I only drink skim milk because my mother in, 89 to 95, did Weight Watchers. And I only really like skim milk, and that's how it's been. But, I'm reaping maybe potential benefits from that now as a 45-year-old man, in that something that's just continued throughout my life.
Awesome. Thank you, gentlemen. Any other questions from anyone out there? Please go ahead and pop it in the chat. Dr. Buford, how about you? You have anything?
Well, I just want to ask both of you gentlemen real quick. We've touched on diabetes, and you and I, we've all talked about the topics. Clearly, we could do 2 or 3 more of these.
Yes.
There is a common misperception about treatment of diabetes regarding medications. Can you speak about therapies like medical therapeutics for diabetes and the variety compared to what used to be? And I know, Brian, you had a very interesting take on this. And I mean, Jonathan, I want you to talk, but Dr. Hall, you had mentioned pumps. So Dr. McGee, I want you to also chime in on that.
You say on pumps?
Well,
yeah.
I will say, so for all of us, the world of technology that Brother Baker can all enlighten us further on, but those things of tomorrow are here today. And so with regard to say glucose monitors, where we're able to have one monitor injected into the arm that is good in place for 3 to 4 days, and then being able to then check our blood sugar on a repeated basis. That is here. That those glucose monitors are now being paid for, because whether it's children or adults, I think we're all seeing that people are testing more, and with more testing and more information, we can keep diabetes in better control. And now for those, and in my world, mostly dealing with type 1 diabetes, and those persons that are really only able to be treated by regular insulin, insulin pumps that deliver both demand and basal rates of insulin, are becoming integrated with the monitors. And so, again, that our general fear of the finger pricks, that we've seen, whether our parents or our grandparents, have to go through, those are becoming, in the past. And again, so, sometimes it's that fear of, if I find out, I have to start pricking my finger, well, the finger pricks aren't going to be there as much. And so let's go on to the doctor and get some tests done so we can, start to treat things.
I would simply add to that. Great comments, by the way, Dr. Hall. We have medication now that will really allow a person to only treat, in some instances, they can take pills orally. we also have injections that, insulin, you inject sometimes just once a day, but sometimes depending on how advanced the diabetes is, people may have to inject with every meal, right? But now we also have medications that are not necessarily insulin that you can inject once a week. And the versions that are, daily as well, but they're just as effective if you inject them weekly. So many opportunities where you can do your shot privately once a week in your own privacy, rather, at home, and not necessarily have to be afraid someone else is going to know your business, and then take your vacation, come back home, and the following week and take another shot, and then really be still a very well-controlled person with diabetes. There's so many options today. It's limitless as far as, like, if you want to control your diabetes, you can do it. And if you don't have a doctor that's willing to take your diabetes seriously, you need to switch doctors quickly.
Good deal. There's a question in here, and I want to be mindful of time. We started a little bit late, so I don't mind going over. The question is, someone injects the Ozempic weekly. What's your thoughts on that drug?
Love Ozempic. There's, there are a few drugs out there that are game changers, and the class of drugs that Ozempic is in, I call the Cadillacs, right? That drug hits so many factors associated with diabetes that you can have the core defects we talk about, rather, with diabetes, right? So several different core defects, and Ozempic knocks out, I think, about 4 to 6 of those. I forget exactly which the number is off the top of my head right now, but that drug works very well. And not only does Ozempic help you with controlling your blood sugars, they rebranded it to make it a weight loss drug called Wegovy. A lot of times people are trying to lose weight. I see it in people with diabetes who are looking to lose a few pounds, and they use the Ozempic to help them to drop their pounds, but also control their blood sugars, right? So lots of benefit in Ozempic. Please continue to use it. It can be a little pricey, but make sure you use your coupons.
There you go. Any other questions? I know we're running out of time here, but we got space for one more. So, as we would say in church, is there one?
Can you all talk about adherence? And I was going to just say, and you can kind of piggyback on this. Even if you have the best drugs available to you, if you are inconsistent, how well are they going to work?
I mean, you can lead a horse to water, but you can't make them drink. And if you are intentional about taking your medications, then you will see the success, right? Again, most doctors, maybe not all of them, people have bad issues from time to time, and doctors are people as well. But by and large, most doctors are very competitive people. We want to win. So we want to see your blood pressure right. We want to see your diabetes in well control. We want to see your cholesterol looking great. We want you to be successful. So if we're giving you something that's not working, we surely want to know that, because I love to see people walk in and they say, hey, everything's good. I'm feeling great. Come on, I'll see you every 6 months. We're good. I just want to have that reassurance that, hey, it's working, right? So similarly, if you're at home and you're not having success because you're monitoring your blood sugars, whether it's finger pricks or you have the device in your arm, right? If you're taking the medications and you're not seeing the effect of that, then that's the time where, again, that ally relationship, right? We're doing this together. I'm simply trying to help you be successful in your own body, right? And I can't help you if you're not willing to help yourself. So please, please do your part and do the exercise, take the medications, eat right, associate with people who do the same, right? It rubs off.
I like to follow up my question of, are you taking your medication with, well, how often do you forget? Plainly and without connotation, because we're human and we're going to forget. And Dr. McGee can, and has done to me, has said, well, it's been a while since you asked for that refill. You should have called me a little bit ago. It happens with all of us. But, as with my theme and what I'm trying to do here, if we're chuckling about that at a follow-up visit with the doctor, and talking about that that funny conversation at my doctor's appointment, with our brothers, with our church members, with our family, that means that even if we didn't take our medication well for the past few months, that we have another opportunity to get back on track, another opportunity to see where our health is, what the status of diseases or conditions that we know we already have is, and opportunities to go forward from there.
Good deal. Good deal. Gentlemen, if you will, we're out of time. Thank you so much for taking this time to come on and educate all of us. You as well, Dr. Buford. I could not have done this without you, my man. I can't stress that enough. Doctors McGee and Hall, if you will, share with us your practice information, as well as any closing words you'd like to leave us with.
I'm happy to go first there, as the full guest here. I would like to say thank you to the brothers of Kappa Alpha Psi, and particularly the Tulsa Alumni chapter. I appreciate you all for having this health summit. I appreciate those who have participated with us. I hope that we've been able to encourage you and inspire you to make those good choices, and even to challenge your family members who may not be interested in doing the best that they can for themselves. So it was awesome for me to be here and to enjoy this time with you all. My practice is Essential MD. I'm located on 101st in South Sheridan. We take just about all of the major health insurance plans, as well as Medicare and Medicaid. So we're just out here trying to serve as many people as we possibly can. If you don't have insurance, we have plans we can help you with as well.
That's awesome. Thank you, Dr. McGee. How about you, Dr. Hall?
So again, I'm a general pediatrician, and I am on faculty here at the OU School of Community Medicine. So that puts me in a particular niche to be able to serve brothers, but again, children and families. I am available so at the OU Schusterman Center, and then I guess I will be getting some calls from the head of reclamation after agreeing to do this. So
it's serious now.
Someone wants to put chapter dues amounts in the chat. Might as well I can start my preparations.
Man, hey, fantastic point to end on, Dr. Hall, Dr. McGee, Dr. Buford, all of our guests. Thank you so much. This was very enlightening. for me. I hope it was for you as well. Dr. McGee, Dr. Hall, if you don't mind, hang out for a little bit. I want to get a little bit of information from you after the call. Thank you, everyone. We appreciate your time.
Thank you.
Right.
Thank you. Great stuff.
Great work, guys.
Appreciate it, Brother McGee.
Yes, sir.
Brother Hall, Brother McGee, thank you very much.
Good seeing both of y'all. I was gonna say
Good
y'all
to
watch
see
Dr.
you.
McGee. Y'all watch Dr. McGee if y'all ever playing the game though, because that brother will get some cheating going on though. You gotta watch it.
That's not fair. That's not fair, Milford. You know how you are.
McGee is good people, man.